audiologists and speech language pathologists, and as well as the physiotherapists, and as well as neuro specialists from medical fraternity. So this day we are going to discuss, we are going to put forward the professionals who are working on certain issues and their expertise on in their area of expert. Like we could see Dr. Praveen Kumar sir, and senior consultant uh, neurologist in KIMS Hospital. We are very much excited to hear from him the topic related to Parkinson's and its recent advances in neurological management and neurologist expectations from SLP and physiotherapy point of view. And as also, we are having one more lecture by Dr. Sunindran Veturi, and from the Department of Physical Medicine and Rehabilitation Sciences, KIMS Hospital. And sir will be talking on advanced physical therapy management in Parkinson's disease. And the next lecture will be followed by Dr. M. Radhika madam, and madam is HOD of diabetics from KIMS Hospital, and madam will be delivering lecture on advanced nutritional management in Parkinson's disease. And the final lecture will be taken care by our Dr. Gangaraju, who is a medical speech language pathologist from KIMS Hospital, and he will be talking on speech swallow issues and aspirations, preventive strategies, and precautions need to be taken in Parkinson's disease. So overall, this program is a mixture of the faculty of medicine as well as rehabilitation sciences, including physiotherapy and speech therapy. So now we would hear from them in a greater way. And first of all, I would like to thank the medical fraternity people and faculty, Dr. Praveen Kumar sir, and Dr. Radhika madam, and Dr. Sudhindran Vituri sir, because you have come forward to give knowledge to both the rehabilitation professionals and as well as medical professionals. Our rehabilitation professionals, and including few special educators and few other professionals, are also joining this program. So all of you, I think you will have good notes at you about these Parkinson's disease in particular, and how to treat, and what is the importance of team management, and what care need to be taken from prevention to the management level. So now I thank once again to our Telangana Audiologists Association, and to the Krishna Institute of Medical Sciences, KIMS Hospital, and our all the participants and distinguished speakers, everyone. And I finally also thank our TASALPA president, secretary, and as well as KIMS Hospital CEO and management, Bhaskar sir, and other people, directors, everyone. Thank you very much, and welcome for this good program. This would be a great initiation for the multidisciplinary approach, both in this topic and as well as in future, to come up with different areas where we can address to the people, and where the lacunas there we can fill up with the current knowledge and advanced trends in that. Thank you very much. I thank Dr. Arif. Please, thank you very much, and please take forward. Thank you.
Thank you so much, sir. Thank you to our respected Honorable Dr. Rajendra Kumar Porika, sir, for your insightful briefing, and also giving introduction about Parkinson's disease, and also your expertise. Definitely, your knowledge and expertise have laid a very good foundation stone for our discussion. So especially, we really appreciate your contribution, because, you have been working behind this since 1 week. Really appreciate your work. And now I would like to call upon our first speaker, panelist, distinguished speaker, Dr. Praveen Kumar Yadav, sir. He is the senior consultant neurologist at Krishna Institute of Medical Sciences. I invite you, sir. Really happy to have you here. So there are so many participants, rehabilitation professionals who want to hear you and also want to learn something really advanced management approaches in treating Parkinson's disease. Sir, please take your floor, sir.
Thank you. Hope I am audible. And possibly I would like to keep it interactive. If there are any points or any clarifications, you can always ask me. And I would in which there is an interaction. Neurologist and the most important other stakeholders, they being physical therapists, speech therapists, and also occupational therapists. As we all know, not even Parkinson's disease, most of the diseases of neurological sciences, there we need lot of support from the family, support from the caregiver, support from the physiotherapy, and all allied specialties, including physiotherapy, occupational therapy, speech therapy, dietetics, and whatnot. Therefore, this is definitely a good initiative, and I applaud the society along with Dr. Gangaraju, who came up with this idea. Now, coming to Parkinson's disease, what the neurologists want when we send a referral. This is the basic point of the meeting. The basic thing is that first of all, we have to realize Parkinson's disease is a neurodegenerative disorder. Neurodegenerative disorder, to the extent we don't have a cure for that. Yes, we have good medications. Yes, there are good advancement in surgeries, but we don't have a cure. Therefore, but as we know, it starts usually in about fifth, sixth decade. So a patient has a life about 30, 40 years. And we have to handhold him over the 30, 40 years so that he has a good productive life. The major symptoms, what we all know, are the motor symptoms. Motor symptoms being rigidity. Rigidity means that is a stiffness of any part of the limb. That is, I believe, most disabling symptom, because with a stiff hand, even though brain is giving command, the hand or leg cannot do the work. The next symptom, other important, is bradykinesia. As the word itself means, slow in movement. There is slowness of talking, there is slowness of eating, slowness of walking. All the activities becomes very slow, to the extent patient has pain in contributing to pain of the body. Third is a resting tremor, the hallmark. In many diseases, we see a slowing and a rigidity. But when there is a resting tremor, that means a shaking when the body is at rest, usually of the hand. That is one of the hallmark. These are the three things: rigidity, bradykinesia, resting tremor. When a person has a combination of all these, we call it as a Parkinson's disease. Is it as simple as that? No, because many diseases at the presentation they present like it, but over a period of time they evolve. Not even that, Parkinson's disease has a big burden of non-motor symptoms. The motor symptoms are all which are visible, but non-motor symptoms, they are not visible, they are not amenable to treatment, and over a period of time they cause big problem rather than the motor symptoms. To start with, you all must be astonished to hear that constipation in a patient starts about 40, 30 years before the onset of Parkinson's disease, right? The motor symptoms. Therefore, severe constipation, body pains. Many times we see patients being treated for periarthritis of shoulder for few years. Then we come to realize that, okay, that was a stiffness or rigidity due to Parkinson's rather than of a shoulder periarthritis. Many times we see a patient being treated for essential tremor. Over a period of time, it turns out to Parkinson's disease. What I mean to say is that These are this is a disease complex, in which symptom complex, in which a disease unravel its over a period of time. Therefore, we normally keep the patient under follow-up, and over a period of time, we make the diagnosis and help the patient. The diagnosis itself of the Parkinson's disease was fascinating. We know that it was first described by James Parkinson by just looking out of his window, looking at the people walking on the road. He could the description what he did about the Parkinson's in his famous essay A Shaking Palsy is remarkable. It said that we also cannot describe as much as he has done. This he had done way back in 1817. Then, in about 1872, the great scientist Charcot named it as Parkinson's disease. But after only about 50 years, Hornquist et al. Found out that, okay, Parkinson's disease is due to deficiency of a chemical called as dopamine. And in 1968, the famous scientist Coates found out that levodopa is the magic treatment which can make a patient stable. It was no less of a discovery than that of insulin, because at that time the Parkinson's patient had nothing. They were just lying down on the bed doing nothing, and giving Syndopa to them was like a magic. The patients who were lying down could walk about, could walk, could eat. Thus, therefore, there was a thought that yes, we have overcome the disease. But as time passed, we know that Syndopa is only, it's just a symptomatic treatment. It is not treating the disease. Therefore, now newer treatments. So, for example, all of you know about the deep brain stimulation, or now a recently non-invasive treatment, that is the radio frequency ultrasound guided functional neurosurgery. What is being proposed, right? That being about that is only done in a subset of patients. What we really see day in and day out are the patients whom we have to deal with medically and with other measures. Till date, Syndopa or the levodopa is the only tablet that works best for the Parkinsonism symptoms. There is a great deal of thought among the doctors that Syndopa can be harmful, therefore don't give it at the full dose. But that is all we should, the myth should be shattered, and we have to realize that Syndopa at adequate dosage. What is the adequate dose? The dose at which the person is mobile, person is doing his activity. That is the adequate dose of Syndopa that each person has to receive. We see prescriptions in which Syndopa half tablet 2 times, 3 times is given. That does nothing. Syndopa, the dose at which the patient is able to walk, that is the dose patient should need. And you know what is the dose? We can reach up to 3000 milligram per day of Parkinson's, of Syndopa in a Parkinson's disease patient. That's it. Therefore, suggest them about the adequate dose of Syndopa. That is the first step we all need to do. Second, what happens is that as Parkinson's disease progresses over a period of time, there are problems. There are gait disturbances. Why does a gait disturbance occur? Right? Because we know when we take Syndopa, patient almost as if the switch is turned down, he comes into the on phase and he does all his activities. As soon as the drug effect goes, patient goes into off stage. That is, electric switch is switched off and patient has become stiff. As we keep on giving Syndopa, as a disease progresses, the dopamine cells are getting destroyed. Therefore, there are few cells are there. Therefore, the dosage is not enough, and you have a frequent on and frequent off stage. And these off stages are the biggest problem. Patient will become stiff. Patient cannot walk. This is the first problem. for the physical therapists. Second problem, right? When they start walking, in few of the patient, they will be having a freezing of gait. What do you mean that? They cannot move forward. They are stuck to a place. That is one another important area where physiotherapists, by simple maneuvers such as like stepping over a step or walking sideways, walking backwards, that is what the physiotherapists they try out many methods and teach the patient to get over this off pace. Third, apart from that, they will have unsteadiness, and gait unsteadiness is the biggest precursor of fall. Our request to the physiotherapist we always is that please teach the patient gait and stance stabilization so that even with the amount of unsteadiness, patient can walk, patient can turn. These are the two to three major problems in when we come across in a early to moderate Parkinson's disease. As the disease progresses, there is a biggest problem of postural instability. What do you mean by postural instability? Patient just falls off. They cannot manage them. This is the great problem because as we know already they are elder. As they fall down, they have a risk of fractures. That is one more area where the physiotherapist they help in maintaining the body mass, the bone mass, and the stance and the gait stabilization so that the patient don't fall. This is about the walking. What about the upper limbs? With the stiffness of upper limbs, they cannot perform their day-to-day activities, cannot brush, cannot eat, cannot put their own buttons. Though our request at that point would be to keep the patient agile, keep the patient independent. As we know, the more the patient gets dependent on others, that's the psychological stressor which will make the disease both worse. Now there are umpteen papers which suggest that adequate physiotherapy. What do you mean by adequate physiotherapy? Active physiotherapy in all the spheres of life. They say Parkinson's disease should do exercise as a boxing player does. A boxer, it seems, works out 15 hours a day. In the same way, a Parkinson's patient should always be active. That's therefore I suggest them to meet the physiotherapist so that they plan out the activities and the patient remains active throughout the day. The next problems come about the speech and the swallow. As I was discussing the important part about the bradykinesia, the same thing affects the speech. The phonation is gone, the articulation is gone, and the respiratory effect is also gone. Therefore, the patient will have a monotonous, slow voice. That creates such a problem. The patient comes and complains, my relatives and all ask me to repeat myself. It is frustrating. I cannot talk on the phone because the other people don't seem to understand me. I cannot go to social places. And that is a big problem. This causes emotional disturbances and patient becomes more and more socially withdrawn. The caregiver do complaints. See, see, my partner who was so active is now reluctant. He doesn't want to go to any parties. And whatever he says, sometimes I'm not able to understand. Please, please do something. And we neurologists, as we know, we don't have medicines for anything, for such a speech problem. Therefore, this is our request to the speech therapist so that, as we know, a good speech therapy goes a long way in maintaining the quality of speech for a Parkinson's disease. Other important problem, quite a problematic, which may think it's a simple, is drooling. In advanced Parkinson's disease, the drooling of saliva is one of the biggest challenges which the patient doesn't accept. We have medicines for that, but the medicines have so many side effects we don't prefer. Therefore, we request our speech therapist to treat strategies so that the patient has had decrease in the drooling. Third important point for a speech is a swallow. Advanced Parkinson's disease, swallow comes down. There is a nasal regurgitation. There is a inadequate chewing. The patient tends to swallow en masse, causing choking. Therefore, our request at that point is that maintain the swallow so that the patient is able to maintain their nutrition. Our request, as we know, to our dietitian, what happens is that we don't make many dietary changes in Parkinson's. But Parkinson's disease keep on losing their weight year after another. Therefore, our request to our dietitian is that to make a diet plan so that they can maintain their muscle mass, bone mass. Once they are able to maintain their muscle mass and bone mass, they can get indulged in the activities, in the physical activities, and able to live their life in a better way. With the advances of medicine, such as the deep brain stimulation, and now the ultrasound, and so many different ways of administration of levodopa, the lifespan of a Parkinson's disease patient is going to increase. But does that mean a proper life? No, there will be many more challenges, all in the physical, social, language, swallow, and other spheres. Therefore, it becomes much more imperative that all the specialties, including the neurologist, the physical therapist, the occupational therapist, speech therapist, dietitian, come together and help the Parkinson's disease to have a good life. This is in simple that I would like to talk about Parkinson's disease. Thank you.
Thank you so much, sir. A special thanks to Dr. Praveen Kumar, sir, as you have given very insightful, very wonderful information about the symptoms of Parkinson's disease, perspectives of neurologist, and also you have briefly highlighted about the different professions also, like we have cognitive symptoms and also communication symptoms, and also you have highlighted some medicines which are very useful, and also what are the challenges which you're facing through your practice. Thank you, sir. We are really happy to have you here. Now, the session is open for the questions. Let's just have some questions, sir. If anybody having any question or regarding this neurological perspective of Parkinson's disease, you can ask. Or else, if anybody would like to, means if you're afraid of directly talking to sir, or else you can write your question in the chat box. Sir will answer you.
Sir,
Hello.
Dr. Praveen sir, very much thankful to you, sir. It was a very enlightened session, sir. Actually, there is an gap between rehabilitation team to medical team. So that today we clarified what the minimum things expected by the neurologist doctor, so that now onwards which can help to reach medical professionals' expectations, and we cleanly follow that whatever the doctor is expecting from us, sir. So very much thankful to you, sir.
Thank you. Thank you.
Yeah, as Dr. Gangaraj was saying that, multidisciplinary approach is very crucial, right? Treating this kind of neurodegenerative diseases. So what I see is, like example, if we take any cricket team, like now we have a festival happening, IPL. In that, if you want some kind of team to perform better, you need to have all the players to perform better. They should apply this whatever skills what they have. If they apply properly, we'll get a proper result. The same way here also apply the same thing. We should have a proper team approach. They should communicate each other collaboratively. If we work with the same patient, maybe we'll get the good results. Thank you, sir, for highlighting on that. So, anybody have any question on the same, you can ask us, or you can write in the chat
Get
box.
back later also. That's not a point.
Yeah.
Okay.
Okay.
Thank Thank you. Thank you for having me for the talk.
Sir,
Thank you so much,
sir,
sir.
I request you to.
Yeah.
Ganga, you are saying something. Hello, Ganga, are you there online?
Yeah, sir, right now. Am
Yeah.
I audible, sir?
Yeah, audible. Please go on.
Sir, please join, sir, and group discussion, sir, and by ending, I think, up to end application, sir.
Okay. Fine. Definitely. Sure. Okay.
Thank
Thank
you,
you.
sir.
Thank you.
Okay, thank you so much, sir. Now we have our second panelist, Honorable Dr. Sudhindra Vuturi. Now I request our distinguished panelist, Dr.
Sir,
Sudhindra
audible, sir?
Vuturi. Yeah.
Sir, Dr. Sita Madam is online, sir. Please welcoming Madam, sir, and
Okay,
welcome,
okay.
Madam.
Yeah.
So, and that the few words about this gathering. So, without Madam, I cannot the initiate this webinar and all this. With Madam blessings only, we started a lot of things, and we follow a lot of things with Madam blessings, and she is always guiding us, and she is always how the SLPs and
Yeah, Gangaraj, go ahead with the meeting. Yeah. We are always there for everybody. We are a team, like Praveen said, no, we are a team. Okay? Yeah, go ahead with the next start.
few words about gathering, Madam.
Yeah. Okay, Rana, very nice to have you discussions like this, which will help us in the management of the patients and improve the patient care. That is the idea of all these meetings. Yeah.
Thank you, Madam. Thank you so much, ma'am.
Yeah. So now we'll move on to our the second panelist, second speaker. Now I'd like to welcome our second panelist, Dr. Sudhindra Vuturi. He's the HOD at Department of Physical Medicine and also Rehabilitation Sciences at KIMS Hospital, Secunderabad. We're happy to have you, sir. We would like to hear something about the advanced physical therapy treatment approaches for Parkinson's disease. You can highlight on this, sir.
Thanks for the introduction. Hope everyone can hear me.
Yeah. It's very
Thank
audible.
you. Can I share my screen?
Yes, sir. I'll make you as a host.
First of all, good afternoon, everyone, and thanks Telangana Audiologists and Speech Language Therapist Association, and also Gangaraj Garu especially for taking out for having me as one of the panelists here. So
yes, sir. Now you're the host, sir. You can share your screen, sir.
Thank you. Can anyone see the presentation or no?
Yeah, now it is getting open. Yes.
Yeah.
Yes, sir. We can see you, sir.
Okay. So I'm Dr. Sudhindra Vuturi. I lead the team of rehabilitation at Krishna Institute of Medical Sciences, KIMS Hospital, Secunderabad, and a very essential part of our team is Gangaraj Garu, who helped me us through. A small summary: I've been in Australia for 6 years, working on a bit of rehab and exercise physiology. Then did my PhD in neurophysiology. And I've been with KIMS for the last 15 years. Now, the moment I would thank Dr. Praveen Kumar Yadav sir for stressing so much on the multidisciplinary approach that is so very well needed for treatment of a multi-pronged disease like Parkinson's. Now, I will not discuss a lot about what happens in Parkinson's disease, but one of the main things which the physiotherapist can definitely help are like the musculoskeletal problems like posture correction, gait, because most of them freeze. That is, after a few steps, they freeze. So the basic principle of physiotherapy in Parkinson's disease, as with most of the neurological diseases, is the neuroplasticity. Now, neuroplasticity in Parkinson's generally, as generally refers to the ability of brain to learn or relearn, learn, unlearn, and relearn kind of stuff. Now, in Parkinson's, the neuroplasticity which we use are if one pathway doesn't work well, Then we use the alternative senses, that is maybe vision or maybe audio or maybe some vibration sense, other senses, so that they can substitute for the sense which is lesser. So this is more or less like a of neuroplasticity. It is also called as neurosubstitution theory. Now there is a mix of internal and external environment. So earlier you must have been thinking like physiotherapy is mostly about helping them walk or mostly about chest physiotherapy and stuff like that. But physiotherapy has evolved in Parkinson's over the last few decades. Now, the first part of my talk, like if you look at the agenda up here, the part of my talk would talk more about the routine physiotherapy. And the second one would be the new advances in non-invasive brain stimulation, that is repetitive transcranial magnetic stimulation. Then we are going to talk about some adaptive devices, like which occupational therapists also use. And then most importantly, how mind and body exercises work. Now, importantly, what role physiotherapy plays is as it was rightly mentioned in the opening remarks by Arif Garu, that it is mostly about the degeneration that happens so fast. It happens like in an exponential way. Now, we generally use a program of stretching and strengthening kind of thing, strengthening for the weaker muscles, and stretching because rigidity is one of the common symptoms, especially rigidity of the upper back muscles, rigidity of the lower back muscles is one of the common, and that influences their activity of daily living. So what we do is kind of balance this, which muscle to stretch, which muscle to strengthen, how much to strengthen, and is it the number of the weights we increase or reduce the weights. And then similarly, most of them have this posture correction. They get into a drooping posture with a chin going forward or poking chin postures. So we try to identify them very early in the disease so that they don't get into worse. Because as most of us know, this poking chin posture completely alters the swallow mechanism. So like it causes unnecessary tension in the laryngeal muscles. So what we try to do is avoid that poking chin posture so that the swallow and other reflexes stay intact as much as possible. And then we take the help of someone like Gangaraj Garu to further strengthen them actually. Then what I would talk now specifically is more about new trends in Parkinson's, like amplitude training and reciprocal movement training, and then where physiotherapists and speech and language therapists together go together in a practice called dual task practice training. Then another gait training, what are the new advances that we get in gait training? Now, when we look at amplitude training, what we understand is most of the patients with Parkinson's, they have very short range of motion. That is, they get freeze. They don't move their joints as much as they want. Now, as Praveen sir mentioned in the first talk, that most of the time, because this reduced amplitude of movements is mostly mistaken as something like a frozen shoulder or a low back ache or a stiff back or ankle pain. And by the time we realize it is actually Parkinson's, then they must have crossed the stage. So first thing is we assess what is the kind of amplitude. So what we look forward is like instead of a normal training, the training in Parkinson's should be pretty much high amplitude. So instead of lifting a shoulder like this, I need to open up shoulder completely. Now, as you look in this images here, and then what happens instead of doing a normal gait, the range of motion and the positivity the brain gets from this amplitude and range of motion should be preserved throughout. So now these are high amplitude exercises. So where you completely use the joint position completely. And then there are few people where it is very difficult to go for postures like this with forward bending. And there are few people who can't stand there. Once the balance issues start in, we get the same thing in supine lying also, where the person can rest in the bed and kind of imitate the same movements like opening up, like when you look at events like this, like abduction of the arms with an high amplitude thing, it also actually tends to open the chest up. So thereby the lung volumes also increase. And then similarly, you can go now here. If you look, even while sitting also, you can mimic these movements. Now, depending on the stage or depending upon the progression of the disease, you can actually start teaching them these exercises either in supine or seated or standing. But the basic principle is they have to be high amplitude. That is, they need to completely open up their arms, open up the chest. Now, if you also observe in these images, what is important is there is also reciprocal. Reciprocal is if the right leg is forward, left leg is back. If the right arm is up, left arm is down. So few of them are reciprocal movements. For example, this is a reciprocal movement. Even because these reciprocal movements will actually try to maintain the reciprocation in gait. For normal, when we walk as a person also, when the left shoulder thrusts forward, the right shoulder goes back. And when the right shoulder thrusts forward, the left shoulder goes back. Now, before a person comes to freeze in Parkinson's, what happens is these reciprocative movements are lost. Now, when these reciprocative movements are lost, then the deterioration musculoskeletal and gait phenomena, they happen very fast. They kind of swirl down in a very fast motion than what happens. So what we look at is something like where we can mimic both the amplitude training and the reciprocal training into one thing. So that's why whenever you have, see, you have, this is a reciprocal movement, one leg is bent and other leg is straight, and then alternate with the other leg. Then this is a reciprocal movement. This is a reciprocal movement sitting down, then reciprocal movement again in sitting, reciprocal movement in standing. So it goes like, it's like the imagination is infinity and you can frame as many exercises as possible. Now, this amplitude and reciprocal training has been shown to reduce or to slowen up what happens at a faster pace, like that is freezing and rigidity. Now, most of us must have also come across videos in YouTube where cycling is known to improve the gait speed, that is walking speed in Parkinson's patient. Now, again, the basic principle why cycling improves is because both the legs move reciprocally. So again, the reciprocative movement really helps them. So whenever we try to see a patient with Parkinson's, we try to do simple things like increase the amplitude and increase the alternative of the movement. Now, then this is where both of us join, that is the physiotherapist and the speech and swallow therapist. Now, if you look at this small little video, which is called dual task training, this is like level 1 and level 2 of this. Hope everyone can see the video. Now, what happens is in this video, we combine high intensity reciprocal movement, and then we combine where the person spells the word. So we can wait SLEEPY, sleepy. Or so this is again, if you go through it, this is a high amplitude movement and alternate hands. So reciprocal movement. Now the person trains with his voice, that is, he spells out these words. Now I would take a pause here. Now what happens in dual task practices in Parkinson's patients, once when we have 2 or more parameters involved, what happens is they tend to freeze more. For example, if the person has to read something or talk to someone and walk at the same time or hold a stick, then 2 or 3 parameters drop in, they tend to freeze. So what here we do is try to get the best of both the worlds. So what we try to do is they try to identify the figure and then whatever it is. Now here this is a virtual one. In the real one, on the wall you can have the letters, and once in they can frame the letters like A, B, C, D. So when they speak out, then that also increases the laryngeal tone. The language therapist really helps us with this, and also it also adds the thing of reciprocal training and also the high amplitude training. Now, once this identification, the language is done, we can again get into something called, we can add a cognitive twist to it. Now, where we go with this? Now here as the video continues, we see like we keep changing the mode. This is again, if you see, both the things these are a reciprocation high amplitude exercises again. Now here what we are looking at is, instead of the language part or the talking part of it, we are looking at cognitive part, where we say go to boxing, go to kicking, mimic cycling. So the moment they keep changing, then each of that changes. So this dual task training is something which is really helpful in Parkinson's again. We'll continue with the video. Like this is like, then this is like a jumping rope. And then again, the yellow goes, then you can add the days of the week. Like Thursday, it is like karate kind of stuff. Friday, it is like baseball. Saturday, it is like yoga or Tai Chi. So something like that. Then Sunday is then relax. So this kind of, as the video goes, you can see that you need to memorize the sport for each day. The moment you say Monday, then you need to get into skipping mode. The moment you do Tuesday, you get into the boxing mode. So what happens is they speak out, cognition, that is they have to memorize, and then physically they have to do this high amplitude and reciprocal training. Now this is one of the latest things which trainings which happen more often in Parkinson's when we as physiotherapists deal with this patient. then gets the gait training. Now, what our routine protocol here involves is to do a functional gait assessment first. Now, functional gait assessment is like an 8-chapter thing where we kind of measure the agility of speed, like the moment get up and go test, where the person sits in the chair, and then the moment we request him to get up and go and come back, we time how much time is he taking. Then second, in the same thing, what we do is also the other criteria involve like person gazing, looking up and walking forward, or looking to a side and walking forward, or looking down and walking forward, or person talking and walking forward. Then how are they able to clear obstacles, or how are they managing staircase and stuff like that. So these 8 phases of gait, functional gait assessment, they actually divide the gait pattern into 8 components like turning, dual component, everything. Now, which component is affected the most? That component we tend to train them by most. Like for example, if a person is having trouble in clearing obstacles, so we have something called as this obstacle training. Or if the person is trying to have freezing episodes, we go for a long thing. Now, interestingly, if you see here, again, the training is high amplitude and also the reciprocative training, whether it is walking, squatting, or whether it is clearing obstacles, or whether it is doing lunges. All of them are boxing again, whether all of them are again high amplitude and reciprocal training. Now, this is traditional gait training. Now, traditional gait training only delays what we would say is like the freezing episodes or the gait freezing, which happens eventually in Parkinson's. But what happens once this freezing episodes during walking set in? Now we are getting new devices here. Now one of them is called this new device, which is NextRide. Now NextRide is a device which you can actually use with any walker or any walking stick. You get them available on Amazon also. In India also, they cost around about 15,000-20,000. Now what NextRide does is whenever a person freezes, so the moment a person freezes, so the NextRide, what it tries to do is it substitutes. So it is a small little device and it goes to the walking stick, or it goes to the cane, or it goes to the walker or any mobility aid. And then what happens is once one pathway in the brain is affected, so it uses the other senses. Now, what are the other senses? Visual sense, or also the auditory sense, or also the vibration sense. So what it does is the NextRide, it kind of projects a laser light which the person will have to change. So thereby we are re-educating the brain to use other pathways for the pathways that are lost. Now what this does is it actually has a beep. So the moment the person freezes, there is a laser line which comes and the person has to follow the laser line. So that is a visual cue. Now, once the visual cue is there and stepping over, so walking it goes divided, the line gives. Then second, there is something called the audio sound. So the moment a person is about to freeze, then what it does is it gives a click sound like a metronome, tick, 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 tick. So what it does is it gives a auditory feedback. And then, so once that is done, a visual feedback and auditory feedback is given. At times, if the freezing is still not going, it also gives a vibratory feeling to the stick. So vibration, which is proprioception, then the tick tick of the metronome, which is an audio feeling, and the laser light, which is a visual. So all these 3 pathways try to kind of substitute for what is lost there. Now this helps especially in the outdoors where obstacle training might be a problem. Now, these are few devices which are hitting the market of late. Now, the most novel thing or most recent thing is the non-invasive brain stimulation, which is like repetitive transcranial magnetic stimulation. Now, repetitive transcranial magnetic stimulation, as in this video, it shows it actually tries to stimulate the area of the brain which is actually taking care of the gait, whether it is a motor area. If the main complaint is aphasia, then the area of aphasia or Broca's. If the area is with the movement, then the motor area. If the area is with the fine movements, then it is the hand. So we use different parts of the homunculus to actually stimulate them. Now, how RTMS works is it sends around about 3 Tesla of MRI, and 2 MRI waves collide, and as you know, like when they cancel each other to provide an electric current or electric field or eddy current. Now this eddy current will change the resting membrane potential of the gray cell. As a result, what happens is then that part will start. Like for example, if you see in this animation, which is repetitive transcranial magnetic stimulation. So we use a 3 Tesla MRI with a coil, and then what it does is it goes, and then we, depending on the depth of the lesion or the area, we try to stimulate, and the motor impulse also is generated, something like that. Now, this generally takes 10 to 12 sessions every 2 to 3 months, so that the person stays active. For example, I would go with this. This is at KIMS actually. If you can see this, then that is the McVenture device we have, and then the coil. That is the pulses being delivered to the person. So you place it on the head after calculating the exact area. And then if you see the hand, there is a twitch going on. Now there are different protocols for it. Now the protocol could be, there are 5 days protocols, there are also 11 days protocols, depends on the severity or depends on the duration. But what is most important is what is the point that you are, and our neurotechnologists, they really help us with the locating the point and everything. So RTMS is something which we have been doing in KIMS for last few days, and then hope we'll get our data also soon. Now, if these things don't help, then as most of the occupational therapists use and physios, we also use our adaptive devices. Now, adaptive devices could be for posture correction, some braces like this, and there are numerous grips or numerous devices which you actually modify your utensils, and all of them are easily available online. For simple things like daily buttoning and stuff, you have magnetic buttons. Then when they get tired, they can sit down. You have walkers and rotators like that. And whenever their spine gets into the kyphotic zone, you have this TLSO braces, which also help them. So but the main thing is the earlier you identify, the more delay the things get, and then these assistive devices can really add to their activities of daily life. Now, as you must have realized, in Parkinson's, it is not just about the body exercise. It is also involving the cognitive episode. And if you must have once we read the literature more often than not, what we find is things like karate, things like cycling, things like tai chi. They really help in Parkinson's patients, and not most of the yoga doesn't much help in the bodily function. That is because in these kind of activities, you have what is called as the repetition, and you have a high amplitude, you have reciprocation, you involve your cognition into it. So what kind of exercise exactly does people with Parkinson have to do is mind body exercises. So that is what, and if you want, you can download this copy of it. It is from American Parkinson's Disease Association, so where you get most of the exercises which the people with Parkinson can go. There you go. That ends my presentation. Hope it was not. Hope it was pretty informative. I'm good for any kind of doubts.
Yeah. Thank you so much, sir. It was very interesting and very informative. Especially, it has connected to the, especially it has activated the prefrontal cortex, which is responsible for focus and attention. So I think many members were really showing much attention towards that, because there are so many new things which we have learned throughout your presentation. Everything was news, because we have not attended so many these kind of very expertise things in the past. So this was definitely informative. Thank you so much, sir, for enlightening and
Yeah.
you would like to
Sir,
add something?
Sir, it was a wonderful session, sir, and it was very informative and not expected, sir. This really it is wonder, sir. So many new things are learned, and SLP can work with physio doctor also, sir. These techniques, dual practice techniques, it is new for SLP industry, sir. Thank you, sir, to introduce this kind of new technique. And also, sir, whichever you are saying that RTMS, it was a new for us, sir. Even we used to go for deep brain stimulations, like that treatment. We used to see a lot of things. But now you are introducing so many new things for the industry, sir, SLP's industry, and as well as your words and your knowledge is always inspiring us, sir. And also, this new treatments and your encouragement also, it can help to industry development, sir. Thank you, sir. Thank you so much for your enlightened session, sir.
Multidisciplinary approach. Thanks, everyone. Thanks for the
No,
opportunity.
no, sir. Actually, things, sir, there is always some queries in between. There is lacking team approach between SLP and as well as the physio doctors. There are a lot of gap is there. But with your encouragement, with your ideology, with your knowledge, we used to do so many new things, sir.
Not in KIMS, not in KIMS. KIMS, we both work together, no?
No, no, sir. Generally, new things always it is helpful for us, sir. And all SLPs now onwards they will practice the same thing, sir.
Dual task and everything. This is where we need to set the standard. This is where forums like this will help us, right?
Yes, sir. Yes, sir. Thank you so much, sir.
Thank you.
Yes, sir. There were so many treatment approaches which you have highlighted, especially RT, MS approach and treatment techniques was very interesting. I think we would like to hear much about it in future. And also dual practice approach, also gait training, and also there are so many things which you have highlighted. It is really new to us. Especially this will help so many speech therapists who are there, who can directly approach you, as you are having good experience in this. So we'll definitely in touch with you, sir. So now let's just open the floor for the questions. Please feel free to ask our panelists anything related to Parkinson's disease in perspectives of physiotherapy. Our experts are here to provide you insights and share their experiences. Please feel free to ask questions. Anybody, any question regarding this? So shall we move on to
Sir,
other
one question, sir.
decision? Okay.
Sir, one question, sir. One question. One question, sir.
Yeah, please ask.
Sir, one question, sir. Arif, sir.
Yeah, please go on. We could able to hear you.
Sir, one question, sir. Sir, one.
Yeah, Ganga, we can hear you. Please ask.
Sir, one question, sir. Arif, sir.
Yes, Ganga.
Sir, one question, sir.
Seven times.
Sir, actually, dual task in that, sir. This dual task in that, sir. How it will help to laryngeal musculature stimulation, sir. How it helps?
It is not about laryngeal musculature stimulation, Gangaraj. It is more towards cognitive side. Cognitive, because not with the swallow, but actually with the speech. Because as the disease progresses, their speech, the number of word count also per minute, everything reduces. And more importantly, the pitch of the voice reduces over a period of time in them. They get a very strilling voice and stuff. So when you have dual task, it is mixture of physical activity with cognitive ability and also increasing the strill or pitch of the voice.
Right.
Yes, sir. Yes, sir. Thank you, sir.
It works in that aspect.
Question in chat box.
Sir, there is a question, sir, in chat box.
Yeah, 1 second. I'll go to this chat box. Okay. There is a question on 1 second, sir. It is getting open. Yeah. There is a question from Dr. Raj Kumar. Sorry, not Raj. How do we assist to swallowing disorders who have Parkinson?
I guess Gangaraj Gar is the right person to answer that.
Yeah. This is the question.
After his talk,
Suitable person to answer. I think that Gangaraj, please, if you have any answer on this, you can. How do we assist to swallowing disorders who have Parkinson?
Disorders with Parkinson. Yeah, sir. I will answer in session, sir. Definitely.
Okay. Dr. Rajkumar, you need to wait for some more time to get this answer. So we'll move on to our next session. Next speaker we have. Shall we?
Yes, please.
Okay, thank you so much, sir. Our Dr. Sudhindra Puturi, sir, for clarifying all the doubts and giving your valuable time. It was so insightful. We would like to associate with you in future also like this. Thank you so much, sir.
Looking forward. Sure. Thank you. Thanks, everyone.
Yeah, yeah. So now we have
Sir,
our
participants, please join us with the discussion, sir, and the ending of the session, sir.
yeah, we'll take this now questions.
I will be there at the end. I will be there during the discussion for sure.
Yes, sir. Yes, sir. Thank you, sir.
Thanks.
Okay, now we'll move on to our next speaker. Now I would like to invite our third speaker, Dr. M. Radhika Garu. Happy to have you here, madam. I think she is the chief director, chief dietitian at KIMS Hospital, and also she is into dietetics. She's at the HOD at dietetics. So we heard about you, madam, a lot about you from Gangaraju, and we happy to have you here. We would like to have more information about what are the dietetics elements of food things in which are very important in treatment and assessment of Parkinson's disease.
Yes, sir. Thanks for the kind introduction. I thank DASILPA, Dr. Gangaraju Garu, and Department of Neurology for giving me this opportunity to present my program. If I can be able to share this, can you help me in sharing this presentation, please?
Yes, ma'am. I'm going to make you as host. You can. 1 second.
Yeah, it says host disabled participant screen sharing.
No, it was not.
Can you please help me out?
1 second, ma'am, because I have shared this to Dr. Sudhindra Vuduri, sir. Now
Okay,
I would like
okay.
to give you host to you. Yeah, now I'll make you as host. Yeah. Yes, ma'am. Now you can share your screen.
So is the screen visible? Yeah.
Yeah, ma'am. It is getting open. Yeah.
Is it visible?
Yes, ma'am. It is visible.
Yeah. So many of them have a question of what they're supposed to eat. There's nothing particular that they are supposed to eat. It's a balanced diet which they have to have. So the general rules are like we need to have a variety of diets, including all the fruits, vegetables, and all the food groups should be included, like carbohydrates, proteins, fats, vitamins, and minerals also. So we need to eat a variety of foods. Of food groups also plays a major role, and at the time at which we are eating is also very important. The time, frequency, and the quantity plays a major role, and also the fluid intake. Plenty of fluids is what is advised, and at least 5 portions of fruits and vegetables per day is also advised. And it will help in the vegetable consumption and the fruit consumption, and having a balanced diet will help in preventing the problems such as constipation, low mood, and even they have reduced bone density, and weight changes are also observed usually. So it's a balanced diet which would help and resolve the issues. So nutrition has a role of both neuroprotective as well as neurodegeneration. So we'll be discussing in the what are neuroprotective foods and neurodegenerative foods. Okay. And increased risk of progression would be the dairy products. So drinking milk may increase one's risk of having the Parkinson's disease. It doesn't mean that they're supposed to completely avoid milk, but there is a restriction of milk which is supposed to be followed, because it plays a major role in balancing the uric acid levels also. Large amount, if you take a large amount of dairy products, they may increase the uric acid levels also, which is inversely correlated with the risk of developing the Parkinson's disease. So it's a balance of uric acid levels in the body has to be maintained. So for that, we need to have a limited quantity, that is around less than 300 ml of milk should be okay, in the form of yogurt, in the form of curds. They can have buttermilk and all also they can have. So the health benefits, as we all know, because of the phytochemicals, they are very good in fruits and vegetables. They may be associated with the declining of with aging, and may help in slowing the progression of Parkinson's disease also. So the intake of fruits, vegetables, and fish also was inversely proportional with the risk of developing Parkinson's disease. The more the intake is, the less is the Parkinson's disease risk. So the trend latent emerging is the Mediterranean diet, which is the latest thing. Even for weight reduction, it is helpful, and even the fatty liver case also, and even the Parkinson's disease also, it is very helpful, as it is a neuroprotective. So most of the fruits and vegetables are the rich sources of antioxidants, and even vitamins also, very essential vitamins being A, D, E, and K, and also vitamin C, so which are present in low levels in Parkinson's disease patients. So a recent investigation also has been studied, where pomegranate juice, it has an oxidative stress and has a capacity of neurodegenerative. As I told you earlier, there are foods which are neurodegenerative as well as neuroprotective. So this is one of the things. The pomegranate juice is supposed to be the degenerative thing. And if you look at the colors of vegetables like white and green, all the antioxidants and phytochemicals are present in the colored fruits usually. It being white and green, you have onions, garlic, and chives, leeks, and all usually, and even greens like broccoli, Brussels sprouts, cabbage, and cauliflower. So greens, yellow, green, orange colored, these are all the rainbow colored fruits which are called as usually. So they are very rich in antioxidants. So these are the fruits and vegetables which are supposed to be consumed in good amount in order to prevent the risk of, or prevent the degenerative changes can be occurring in the Parkinson's disease. So green, as I discussed, broccoli, Brussels sprouts, and all. Yellow and green, asparagus and green spinach and all are available. Squashes, lemon, and all. Orange and yellow, cantaloupe, nectarines, and even oranges. Papaya is the best source. Peaches are also available. Oranges, like orange colored ones, they contain good amount of alpha and beta carotenes. These are all the phytochemicals like allyl sulfides, indoles, lutein, zeaxanthin, and flavonoids are present, and alpha and beta carotene. So they which are present in carrots, mango, and pumpkin. And purple colored fruits, they contain anthocyanins and polyphenols. They are present in berries, grapes. Dark colored, dark violet and purple colored vegetables, they are present. Fruits, they are present. And red is lycopene, as we all know, it is present in tomato. So these are all the colored fruits and vegetables which are very, very needed for a Parkinson's disease patient. So very important thing is like even the omega-3 polyunsaturated POOPH is called as, that is also a neuroprotective. And around one study is there which reduced the depression also in Parkinson's disease patient, which was conducted in 2008. So and docosahexaenoic acid, DHA, is also one of the essential factors, as we all know. It is very much essential in so it's a anti-inflammatory potential, it has anti-inflammatory potential. And coming coffee have been shown which helps in even Alzheimer's also, and coffee drinkers at least 2 to 3 times per day have been shown to shown a very significant a decrease in the risk of developing liver cancer and cirrhosis also for Parkinson's disease also is very helpful. And green tea is associated with decreasing the regular it has shown to prevent colorectal, lung, and prostate, and even ovarian cancers also it can reduce. So at least 1 to 3 cups of the black or green tea has been linked to develop the linked to the lowering risk of developing Parkinson's. Fat, as I discussed earlier, MUFA and PUFA are very much essential in preventing the risk of Parkinson's disease. These are the various sources of monounsaturated fatty acids, like we have avocados, olive oil, canola, safflower oil, peanut butter, sesame oil, that is still oil, peanut and olives, nuts and seeds. These are all very rich in MUFAs, and they're all neuroprotective. And PUFAs, they are present in fatty fish like salmon, mackerel, herring, and even sunflower oil is a rich source of PUFAs. Corn oil, seeds, these days flax seeds are also available and suggested for the patients. Flaxseed oil is present, and even safflower oil present, which is helpful. Fatty acids are very important, whereas saturated fats have no in helping the risk of Parkinson's disease. Where these are very, very important constituents of unsaturated fatty acids, very, very important constituents of have a decreased brain function. Studies have shown that MUFA, PUFA decrease monounsaturated fatty acid and polyunsaturated fatty acid deficiency have shown a decrease in the brain function also. So, but it doesn't mean that fat should be consumed in more quantity. Like cakes, biscuits, and pastries, they contain a lot of calories, and obesity and all also have been shown to slow down the progress. I mean, slow down the activity level of the brain functioning also. If you take more of carbohydrate-rich food or calorie-rich food, so they have to be reduced. If you are trying, if the patient is obese or overweight, they are supposed to be, the calories are supposed to be reduced. So in case of high cholesterol or diabetes, advice from a dietitian is it becomes necessary. So meat, lean cuts of meats are very good sources of protein which are needed. So also they are rich in iron, and oily fish, eggs, and beans, pulses, nuts, all rich in good source. They are rich in iron. And vegetable based, even meat alternatives, if the person is a vegetarian, they can consume even tofu, that is nothing but it is the paneer made of soya bean, and even some microproteins also they can consume. And even beef consumers, eggs, if they are consuming lamb, beans, and pulses also, they are rich in iron. But it should be noted that red meat, it's high in calories and fat also, that needs to be restricted in the diet. So the carbohydrates, if you look at, they form the 3/4 of the diet, at least consists of carbohydrates. Even with the carbohydrates, the unpolished rice or the whole grains and all, they contain good amount of fiber, calcium, iron, and B vitamins also. Continuous washing or continuous soaking and discarding the water will remove all the B complex vitamins. So care should be taken that the washing is limited and fiber is retained in that. And eating whole grains such as whole meal bread and all, they keep us fuller for a longer time, and there will not be any craving to eat any sweets or consumption of any high fiber foods. Include whole grain foods which have fiber in them and B complex vitamins also. So potatoes with skin are okay, but without skin, removing the skin and all, they are equal to that of a starch only. So we need to keep an eye on fats also while cooking. We should see that no more added salt or oil is put while cooking rice and all. So restricted quantity of boiled vegetables with little seasoning of oil can be given, but not deep frying and all. Shallow frying should be okay, or grilled form, or boiled form, or roasted, toasted form can be consumed. So protein, definitely it affects the time with which you are giving the protein. At least 30 to 45 minutes. The medication has to be given 30 to 45 minutes before meals. So because it interferes with the absorption also and the functioning also. So main protein meal in the evening, it can be taken as a slow response to medication. The metabolic rate also slows down when it is evening. It's a high metabolic rate also. Doesn't mean that protein intake should be stopped completely, but it is needed. Protein is very much needed for the preservation of muscle mass and all, and even renewal also, tissue renewal also it is needed, and even for the self defense also, the antibody formation also, and infection, fighting the infections also, which is needed. So reducing protein, it may drastically cause weight loss, which is not an acceptable thing. So the weight loss from the protein is very dangerous, whereas fat loss can be okay achieved by calorie restriction and all we can do, but protein, where it is not restricted in the diet. So dehydration, as we all know, it can cause symptoms worst, including low blood pressure, dizziness, and even constipation also can be caused because of low fluids. So we need to look into the fluid intake also, and avoid dehydration as much as possible. So water is the easiest way, where you can give water, like juices can be consumed, tea, milk, coffee, and even some sugary beverages with little quantity of sugar, like coconut can give them, and even some barley water or sago water can be given. Some fruit milkshakes can be given to a patient. So it is fruit juices, but high sugar levels may not be an ideal advice. Very light sugar fluids or juices can be given. So constipation is one of the major things which is observed in the patient. So as discussed with you, the fiber content is very important. Exercise is very important, and even drinking more and more of fluids, adequate quantity of fluids to decrease the dehydration is also important. So fiber, it is found in various cereals, seeds, as I discussed with you, pumpkin seeds, sunflower seeds and all. Some good amount of nuts can be taken. All the fruits and vegetables do contain fiber. Even pulses with whole grains like chana, rajma and all with the skin. They contain sorts of dals with skin. They are rich in fiber. The refined ones are the skins which are removed. They but the ones with the salt take, it is already available, but the more and more quantity of salt is also not a good indicator. Table salt or top salt should be stopped. Whatever is present, food items that can be consumed, all the processed foods, snacks, chips and all, ready to eat foods and all contain lots of salts in them. So salt has to, and also food labels while having. And vitamin D, very much prevalent in Parkinson's disease patients. That has to be very much understood. So that has to be taken care. Vitamin D has to be taken care. They have to be taking, even as per the doctor's advice, the calcium and even vitamin D supplementation. Especially those are bound and immobile, and they cannot go to the near the sunlight and all. If they are very much restricted to the bed, they're supposed to be exposed to the sunlight. So if they can't do that, at least vitamin D has to be given to them. Vitamin D also. So exposure to sunlight is the easiest way, and even absorption of calcium also can take place in presence of vitamin D, as we all know. So for that purpose also, vitamin D is very important. And consuming some oily fish and even salmon, sardines and mackerel, the types of fishes, consumption of them also gives you good amount of vitamin D. And fortified, these days we observe fortification of iron and vitamin D rich cereals are also available. Some cornflakes are also rich in vitamin D, iron and all. So those also can be taken. And egg yolk, the yellow part of the egg is also very much rich in vitamin D. That also can be consumed. We need not avoid that, thinking that it is rich in fat or it has good amount of vitamin D also. And lean meat cuts can be consumed instead of fatty cuts. You can have the lean meat cuts. Coming to the vitamin C or ascorbate, it is highly concentrated in the central nervous system and is a neuroprotective. So any anti-infective, as we all know, and it has a promising results in reducing the lipid peroxidation and increases the catalytic activity. And it correlates with the higher the intake of vitamin C, it correlates with an increased risk of like in some studies it has been shown. In contrast, there may be even case studies where vitamin C is consumed. They show a 40% reduction in the Parkinson's disease risk also. One more very important vitamin is vitamin E supplementation also has been shown a protective effect, and pre-treatment reduces the lipid peroxidation. So vitamin D is very essential because it has vitamin D benefits are to its chain breaking capacities in the biological membranes. It prevents the oxidative damage by trapping the reactive radicals. Another one is B12, very important, and folate deficiency. Levodopa may have lower levels of vitamin B12. Once that is consumed, it may have an effect on vitamin B12 and vitamin B9 also. And symptoms can include pins and needles, the paresthesia symptoms, soreness and redness of the tongue, and even mouth ulcers can be there, and even disturbed vision abnormalities also can be seen. And because of all these things, soreness and redness of the tongue, the patient may not be able to consume the food also properly. They may have, even if they are given little small quantity also, they cannot consume more. So that care should be taken, vitamin B12 and folate deficiency. And one more very important is antioxidants, but we need not consume antioxidants in the form of a pill or anything, but balanced diet can give you the required antioxidants, because there is no much evidence that it will slow down progression or anything, but to give the good amount of fiber, to give the body good amount of fiber and vitamins, the fruits and vegetables can be taken in amounts. Excess amounts have a negative effect only ultimately. It has no positive effect. So coenzyme Q10 also, it has a strong antioxidant property. It is present in wide, very small quantities. In beef it is present, soybean oil and oily fish it is present. So it is essential for providing the energy to the body cells also. So cells require energy, means like if cells have to get proper energy, coenzyme Q10 is very essential. So low blood pressure, it is observed usually in the Parkinson's patients. So when there is increased demand supply of blood, but after the meals, such as meals, after consuming the meals and all, the stomach and intestines require more blood, whereas from the brain it is transferred to the stomach and the intestines, which lowers the blood pressure ultimately. So whenever body is dehydrated, the situation or the symptoms can be even worsened. So this occurs because of lack of fluids or salts in the diet. And also one of the important factors is too much consumption of caffeine also has been suggested, like it causes, they have a dehydrating property, they cause dehydration. So it is better to drink water in between any alcohol. If it is suggested by the doctor or any they are consuming, it is always better to consume water, because it will definitely cause, alcohol will cause dehydration. If constipation is a problem, so effort straining, if the patient strains much, if there is a lot of pressure put in order to relieve the constipation also, it may lead to low blood pressure. So these are the neurodegenerative and neuroprotective foods. Milk, as we discussed, more quantity is a neurodegenerative one, whereas neuroprotective are omega-3 vegetables, carotenoids, genistein, and even tea, caffeine and all, they are present. And MUFA, PUFA, these studies have to be conducted. These studies are supposed to be conducted. So one more very important symptom observed is indigestion and heartburn. So such as eating small frequent meals is very important. Instead of consuming food at once, it's always good to be consuming very small and frequent meals. Every second hourly meal, some liquids can be given, some fruits and semi-solid diet, some porridges can be given, some milkshakes can be given. Okay, for example, alcohol, coffee or chocolates, tomatoes, these are the various types of foods, spicy foods, they may trigger the heartburn. So it is always better to avoid or at least limit these specific foods. So there are upcoming studies, latest studies on specific diets like ketogenic diet, because in order to safeguard the gut microbiome and all, where some quantity of MCT oil based diets, there are studies ongoing, and even psyllium husk and even wheat bran also there are studies, and even gluten free diets also they are conducting studies, and protein patterns, how protein patterns are and nicotinamide riboside consumption also, like they have supplemented for around 3000 mg per day for a period of 12 weeks. So these all studies are upcoming. So one more very important thing observed is eating and swallowing difficulties. So how to, I think our Dr. Gangaraju sir will help us in helping out, I mean, solving this issue. So some tips from my end also, if there is any difficulty in swallowing, example cough when eating or drinking, or difficulty while eating or drinking fluids, and taking a longer time to chew and all. So these are the usual difficulties which are observed. So there are special cutleries which are available, like knife and fork, all in one, fork, spoon and all, where they can easily handle. There is a grip also, easy grip, with which they can handle the liquids or the solids in a very good manner. So this is even the knife also is in this manner that they can hold it properly, and even they can avoid any injuries by cutting in a proper manner. So this is one type of cup which is available. The tumble knot mugs they are called as. The non-slip bases will be there with tall necks and all, so that it doesn't slip. The liquid doesn't slip. Nosy cups are also available. And this is a type of cutlery where they can eat with a specified specialized spoons, and plates are also available. And Dyson mat, this blue color one is called as a mat, which is anti-slippery. So there are even plate guards also, which guard the plate from slipping. Also there is one more thing is stay warm plate, where the food remains warm for a longer time. Sorry. So the special cutlery for the Parkinson's disease patient. And these are the spoons which are available. And thank you for the wonderful opportunity which has been given for me to present various advanced nutrition requirements in Parkinson's disease patients. Thank you.
Thank you so much, madam. Special thanks to you for highlighting what kind of food a Parkinson's disease patient should take or should not take, and also you have highlighted what are the different approaches you have, different food items you should take, and also you have highlighted some omega-3 fatty acids. Also you have highlighted, and also you have beautifully highlighted the role of dietitian in Parkinson's disease. I think most of our participants, especially, gain so much of knowledge about what are the different means foods you should counsel the patient with Parkinson's disease. It was so insightful, madam. I request our participants, if you have any kind of question, please you can ask our Dr. Radhika, madam. She is available. Or else you can type in the chat box. We will ask her the same question.
Yeah. Thank you, Dr. Radhika, madam. So, such a wonderful session regarding the food medicine. Food is a medicine. Hope we all understand that SLPs and PETs and all the clinical nutritionists, they can place a major role as nutrition is the main important to maintain the mass patient body mass effect. So in your lecture we learned a lot of things, madam. So whichever you presented, that enlightened us. Thank you so much for your wonderful presentation, madam. So I know you are very much interested in clinical nutrition about the neurological patient. Thank you, madam. Your suggestions and your knowledge is valid for us. Thank you so much, madam.
Thank you. Thank you. Thank you for giving me this opportunity.
Sir, please make Dr. Rajendra sir as a host.
Yeah, sure. Madam, I have one question. The question is like persons with Parkinson's disease who's having diabetes. What kind of food do you recommend, ma'am?
It will be a diabetic restricted diet, sir. As already discussed, the sugary things and all, we need to cut down on the sugary part. We need to avoid, and it remains almost the same. I have taken the guidelines in such a way that it will be useful for almost all the diseases, common for all the. So even the fruit juices thing and all, we need to avoid. There are small semi-solid, it can be made into a puree kind of thing, and it can be given to a patient. And all the diabetic dietary guidelines remain the same for as it is for a diabetic patient, sir.
Okay. Thank you, ma'am. Thank you for the clarification. Thank you so much, ma'am.
Thank you, sir.
Sir, make
yeah.
Dr. Rajendra Kumar sir as a host, sir.
Sure. We'll wait for some more the questions if anybody is
Yeah, sure, sir. Yes.
willing to ask. Somebody has raised a question. Silpa Jasti. Somebody has some.
Yes.
Yeah.
Hi, ma'am. I just want to ask, my father is diagnosed with Parkinson's. He's a diabetic from many years.
Okay,
Most of the time, he complains that he has stomach pain.
Okay, ma'am. How is his bowel movement, ma'am? Is he able to pass the motion and all? Any constipation is complaining of?
Issues are, he complains that, but okay. But main thing is the stomach
So
only.
maybe
He says
the fiber.
yeah. Yes, ma'am.
Yeah, ma'am. Please tell me, ma'am.
Yeah, the constipation and everything is fine, but not he doesn't feel that he is properly doing that bowel movement and everything. So that is the reason he is not able to eat also proper. He says like max to max one idli or two idlis he will eat. He's a diabetic from many years, like nearly 20 years, I think.
Yeah. As I discussed, ma'am, in the presentation, small and frequent meals is what is advised for him, ma'am, and good amount of fiber also you need to take in the diet, ma'am.
Okay. Ma'am, if
With
possible,
good
can you
amount of
please
hydration.
hydration? Okay.
Hydration is also very, very important, ma'am. Just see to it that he is properly hydrated, a good amount of fluids also in between. And small and
Okay.
frequent meals are also very, very important for him. He being a diabetic, because we don't want his sugar levels also to come down. Hypoglycemia is also
Yeah.
very important thing which
Yeah.
we need to consider.
So what
So
kind
we
of
need to see
fluids
to
we
it
can
that
give?
you can give any porridges kind of thing, oats porridge you can give in the between soups you can give.
Okay.
Some fruits also in the pureed form. If he is able to chew and take, that's okay. Otherwise, you can give it in the form
Yeah,
of a
he's
pureed
able to
form.
chew.
Papaya, chew, okay.
Okay.
Papaya fruit you can give him. You can give him even apple also is a very good fiber containing food which you can give him.
Okay.
Even
Okay.
vitamin C rich food such as sweet lime you can give him, or which is mosambi, and even orange can be given for
Okay.
him.
Okay.
So at times you can have even watermelon also, which is having good hydration capacity these days. For this summer, you
Yeah.
can have
Yeah.
good amount
Yes,
of
ma'am.
watermelon also, like around 100 grams you can have. So that is
Sure.
also protected for him.
Okay. Ma'am, is it possible
Okay.
to share this nutrition, because I missed that session? I forgot it. So is it
Okay,
possible
ma'am.
to share it?
Sure, ma'am. We take care to that. Not a problem.
Sure. Thank you, ma'am. Thank
Okay.
you.
Thank you so much, madam, for clarifying all the doubts which are asked by our participants. And thank you so much for giving your valuable time and coming all the way, and also giving your insights. Now we'll move on to, I think, anybody has any question? I think.
Sir, Rajendra sir, unmute చేయండి sir. Dr. Arif sir.
Yeah, one second. Hold on. 1 second. I'll make him. I think he's the host now.
Sir, please unmute sir from your end.
Yeah. Sir, okay. Shall we move on to next session?
Yes, sir.
Yeah. So now I would like to invite our distinguished speaker, Dr. Gangaraju. He is the medical speech language pathologist working at KIMS Hospital. He will be talking about speech swallow issues and aspiration preventive strategies, precautions in Parkinson's disease. Thank you, Gangaraju, for organizing this kind of webinar. And also thank you for collaborating with all the other medical professionals, and also allied health medical professionals who have given very very good information Now, we like to hear you something about the speech and swallowing issues and also aspiration issues in Parkinson's disease. Over to you, Dr. Gangaraju.
Thank you so much, sir. Sir, can you please unmute Dr. Rajendra Kumar sir Porika?
No, he's the host
Yes, sir.
now. He can do it from his end. He's the host now.
Okay.
Is it not happening? Just 1 second. What I'll reclaim it as a host. You are the host now. Now 1 second. I'll again give you this hosting facility so that you can again do this. 1 second.
Yes, sir.
Unmute. Yeah, now I'm making him as a host. Yeah, now you can unmute yourself. Ganga, please go on. Dr. Gangaraju, are you there online? Please unmute
Sir,
yourself.
joining, sir, joining.
Unmute,
1 minute. Sir.
yeah, unmute yourself and talk. Unmute your audio and talk.
Yes, sir.
Yeah.
Map post teacher. Sir, please make a host. Hello, sir. Hello, Arif, sir.
Gangaraju, you are already the host. I have given you the
No,
host.
not me, sir. Sir, please make Rajendra sir as a host.
Yes, it is on the name of Rajendra Kumar, Dr. Rajendra Kumar. He is the host now. You can start sharing your screen.
It is not coming, sir.
Host disabled attendance.
Host disabled attended screen sharing, sir.
Host himself disabled, right? I think 1 second. It should happen from your end. So again, I'm making him as a host now. See?
Dr. Arif,
Yes.
please make me as a host. He is on my system to present PPT.
That is what since 10 minutes I've been doing this. I don't know why it is not happening. See now, just check it out once.
Hello.
Yeah. Now it's coming.
Now it is coming.
Yeah.
Yeah. Are you able to see the screen?
Yeah. It is getting open now. Let's wait some time. Yeah. It's not yet open. Still. Yeah, no, again, it is double click on that, sir, so that it will show you. Yeah. I request all the participants to be online. We are working on that. Maybe there could be some kind of technical glitch. Just wait for some more time. We're working on that. Hello. హలో ఎస్ సార్
వాయిస్ రావట్లేదు, ఇద్దరు ముగ్గురు మెసేజ్ పెడుతున్నారు.
అదే సార్ ఈయన వీళ్ళకి ఏం చేయాలి సార్ చెప్పాలి వీళ్ళకి ఏం 1 సెకండ్ సార్.
అదే
హలో. హలో డాక్టర్ గంగరాజు.
पर उसको लगा और जरूरत ना पड़ने पर मैं उसको हटा। मिस्त्री मकान मालिक की बात सुनकर अपने काम पर लग गया और
Hello, Gangaraju, are you online? Hello, can you hear me now? Gangaraju, are you online? Is it audible to you? Hello, Ganga.
As a audience, we are able to hear.
But where is he? He's not responding to us. What is happening with him? Because now I tried sharing my screen. Now he can talk directly without any this thing. Glitch.
Gangaraju, we are unable to hear you.
Gangaraju, unmute yourself and talk now. No, your PPT is being shared by me. You can go on.
Okay, sir. Sir, now am I audible, sir, right now?
Yeah, it's very audible. You can go.
Now you are audible after 15 minutes.
I already completed my all things, sir, but okay. No problem, sir. Okay. First slide, sir.
Yeah, first slide.
Sir, good evening, everyone. Myself, Dr. Gangaraju. I'm a medical speech language pathologist, KIMS Hospitals, and I'm as a TASALPA EC member. Yes. Next slide, sir. Sir, next slide.
Yeah, one second. Not moving. What is the issue?
Next slide.
Sir, next slide.
Yeah, go on.
Next slide.
How are you going?
So, first slide, Gillen, sir.
So going back, right? Yeah. 1 second. Yeah, now go on. Take it.
So, today my topic is speech and swallowing assessment and management and preventive strategies in persons with Parkinson's disease. Persons with Parkinson's disease. So, first of all, we want to know that so Parkinson's disease is a neurodegenerative disorder and depigmentation in the basal ganglia as well as dopamine cell death. Due to that, this Parkinson's condition will occur. Sir, next slide, sir.
Yeah, okay.
Causes of speech and swallowing difficulties in Parkinson's. Generally, the basal ganglia will depigmented, or it will affect all the structures of the all the functions of the face and as well as nerves, which is causing swallowing difficulties as well as speech difficulties. And in persons, it affects the areas of brain that controls the speech mechanism, which is causing for speech difficulties. Parkinson's affect our oral proprioception. See, the Parkinson's persons, the reduced oral sensorium as well as oral proprioception. How if it is, they may not recognize the food, whether it is a food present in their oral cavity or not. They will unable to find out that. They will unable to initiate that due to that oral proprioception. And Parkinson's can reduce sensory awareness, like changes changes their voice, speech, and rate of speech. Also, see the due to auditory lacking of auditory feedback, the persons may not aware about their voice quality as well as pitch quality and rate of speech. How much speed they are maintaining in speech, they are unable to recognize. So in Parkinson, the muscles and nerves responsible for swallowing get weak and affect the swallowing. So which is causing in general speech patterns as well as swallowing patterns. Next slide, sir.
Yeah.
Speech in Parkinson's. See, in general, in Parkinson's disease, voice and speech changes are often the earliest signs of Parkinson's disease, and also it will be biomarker to detect the early identification of Parkinson's disease. But not everyone with Parkinson's disease will have the same symptoms like that, the speech difficulties. So the speech symptoms may be the reduced speech quality and hoarse voice and breathy voice, monotonal voice, shaky voice, or difficulty with letter pronunciation, cognition, slurring of certain letters, and changing rate of speech and changing the voice pitch and difficulty finding right word to speak out to initiate their communication. See, so reduced speaking volume. Why? Because of in Parkinson's disease, the reduced dopamine level or basal ganglia depigmentation that causing the motor movement delay. Due to that delay, the patient speech and swallowing skills highly time-based mechanism. See, if it is due to movement slowness, if it is the patient drag their oral cavity as well as oral articulators, that will causing this dysarthria, and as well as in that will affect the speech rate. In normal for example, normal person can speak 50 to 100 words in a minute. But whereas come to Parkinson's disease, the patient may not maintain that much of speech rate due to that oral articulators dragging and inability to move faster. Due to that, the patient may not maintain adequate speech rate. So, monotonal voice. That in general, what is speech? Okay, speech is a dynamic production of voice sounds through the process of respiration, phonation, articulation, and resonation. See, when the Parkinson's affect the all the systems, so in speech systems, all speech systems will affect in Parkinson's due to that depigmentation or reduced dopamine levels. So that the furthermost symptom monotonous voice. So aerodynamics will reduce their quality of voice. So they may not maintain sufficient aerodigestive dynamics. So due to that, the patient have the monotone voice. Sir, next slide, sir.
Yeah.
See, symptoms of swallowing difficulty in Parkinson's. As we discussed, that Parkinson's will affect the movement of articulators. So, see, swallowing is a movement disorder. It is timely coordinated activity. Due to that slowness and reduced oral perception and reduced oral motor movement will cause aspiration. So how what in the persons with the Parkinson's? Coughing, especially in the night time, the patient may come half and complain, sir, while we are sleeping, we are getting more coughs, or we are getting choking when we are eating or drinking liquids and food. See, the patient may feel lower sensation. Something is stuck in my throat and I'm unable to gulping. So the patient may often say like that. And having trouble swallowing pills also, sir, I am unable to sir. Am I audible, sir?
Yeah, audible. Please go on.
So I'm unable to.
I think at your area network is very poor. Again, we could not able to see your screen. Ganga, can you hear me? Please check your internet connection. I think we disconnected the again. Hello, Ganga. I request once again you to reconnect with the same. I think you have disconnected yourself. Can you hear me, Ganga?
Yes, sir.
Sir, yes, sir. Please wait 1 minute, sir.
Yeah.
Ganga,
Sir,
when
now-
you present next time, you should be sitting in 17th floor of KIMS hospital, which will be near to the tower.
Hello.
Hello, sir. I'm audible.
Yeah, audible. Please go on.
Yeah. Am I audible, sir, right now? Am I able?
Yes,
Yes, yes,
Ganga,
yes.
please.
Sir, in sir, can you?
Yeah, tell me. What should I do? Please tell me, Ganga. Again, he has gone back to same. Please check your internet connection, Ganga. I think you're at the place where internet connection is very poor, I think.
Hello.
Ganga.
Hello, sir.
Yes, yes.
Sir, am I visible, sir?
Yeah, visible and also audible. Please go. I think not visible. Yeah, please turn on your camera.
I turned on it, sir.
Okay, please go on. Go on, please. See, the participants are waiting for us since long time, though in spite of several glitches, they're waiting to listen to your lecture. Ganga, again you have disconnected yourself.
Hello.
Yeah, Ganga. Now we can see you and we can hear you. Yeah, please go on.
Yes, sir.
Yeah,
And
listen.
having trouble swallowing pills
Ganga,
and
just 1 minute. We should be very much thankful to all our participants. In spite of several glitches, they did not disconnect our meeting. They're still waiting for us. They're still waiting for you to connect and deliver your speech. Yes, really thankful to all.
yeah, thank you so much. Sorry for interruption. And see, more than 80% of the patient with Parkinson disease, they may face swallowing difficulties, and these swallowing difficulties will cause serious swallowing issues such as aspiration pneumonia, like that. And the patient may complain often, coughing or choking when eating or drinking liquids. Global sensation, a sensation of food sucking, throat sucking, and having trouble swallowing pills, a tongue magnetism. So we are unable to move my tongue in adequate manner. They used to complain the same thing. And poor oral proprioception will be there. Poor oral proprioception, there is a reduced oral sensorium, and the oral preparation. Due to that oral proprioception, the patient may not swallow timely, adequately. Delayed oropharyngeal propulsion due to that poor oral proprioception, as well as the apraxia of speech. And so intermittent swallow intermittent swallow pauses may seen. Why? Because of that, due to that misarticulation, the patient may not swallow adequately. So due to that, he will feel, sir, I am unable to chew. They used to complain the same thing. So nasal regurgitation and drooping due to that facial musculature strength weakening. So the patient have been complaining drooling. like that. Repeated aspiration pneumonia due to that laryngeal musculature weakening. Due to that, the patient bulbar strength, bulbar weakness. Due to that, the patient often complain, sir, we are feeling excessive cough while eating or drinking, sir. So we are unable to swallow. They used to complain the same thing, and food or stomach acid backing up into the throat, and malnutrition and weight loss will be present in persons with swallowing difficulties. Sir, next time.
Yeah.
So, how are speech and swallowing issues? Sir, full slide are not coming, sir.
We could able to see the full slide, but I think at your end, poor connection because of poor internet connection, you could not able to see. Just see.
Sir, how are speech and swallowing issues will addressed by the SLP? So SLP will take a call according to the patient current status, and he may choose the different kinds of diagnostic tools such as complete detailed medical history and speech mechanism evaluation and voice mechanism evaluation and bedside swallowing evaluations and flexible endoscopics examination of swallowing and modified barium swallow study, full day oral intake safety observation. He may choose the different kinds of these kinds of diagnostic tools. In speech mechanism, SLP will assess the oromotor mechanism coordination as well as oral, if it is there any oral secretion or and oral sensorium, he will be evaluated. He will evaluated. And voice mechanism, if SLP will assess the laryngeal system and that if it is there any secretions and piriform fossas or the epiglottic elevation and movement and vocal cord movement and the false vocal cord mobility and the laryngeal musculature tone, he will assess that. After that, he may assess the bedside swallowing evaluation. SLP can introduce different kinds of and different texture of foods while bedside swallowing evaluations. He will introduce liquids and semi-solids as well as pseudo swallow. So by observing the patient patterns, and if he will suspect any aspiration, he may go for a flexible endoscopic evaluation of swallowing. In that, he can visualize the patient swallowing directly, so that he can understand the swallowing mechanism, how it is affecting this musculature and the bulbar system is how it affecting the swallowing mechanism. So he can understand, and he can introduce according to the diagnosis. He can introduce the appropriate treatment and modified barium swallow. Still, if it is there any queries in flexible fiber optic endoscopic swallowing studies also, he may recommend the modified barium swallow study. In that, we SLP and radiologist, they can evaluate entire the system, how the swallowing patterns happening, where the aspiration is occurring, and after that, patient may observe the full day oral intake safety. Sir, next.
Yeah.
See, in general, what therapies can help to improve the speech and swallowing mechanism? The SLP can choose different kind of treatment strategies such as speech therapeutics, voice therapeutics, and language therapeutics, and other techniques. So in speech therapy techniques, he can train the patient on articulation. So in articulation is nothing but oromotor exercises and all. And phonation and respiration. These are the SLP will focus on phonatory exercises, which is causing movement of the vocal cord or epiglottis. By doing this, we can achieve these those functions. So After that, SLP will teach the prosthetic factors and as well as he may use that Silverman techniques necessary. So in voice therapeutics, anning, relaxation, delayed auditory feedback techniques we used to use in general, and language therapeutics and techniques we'll generally we'll focus mainly on cognitive factors and speech production training. So the place of articulation and manner of articulation we used to train the patient. And feedback techniques we used to use that visual feedback, auditory feedback, and the tactile feedback, and counseling and medical interventions also that can minimize the swallowing difficulty by doing the dose adjustment. Next, sir. Sir, next. So those are the speech therapy techniques. Speech and swallowing in general therapeutic techniques, and also it is a there will be available and compensatory strategies such as body and neck position alignment changes, or utensils modification, and food texture modification, thickening agent. So such as like thicken up clear like that. Those things we used to use that modify the viscosity of the fluid and all. See the body in general, body and neck position. What will be happen? So in general, doctor will come make the proper position. They may be suggested. After that, our people will follow the just elevation. That just elevation will they may not it may not helpful. Why? Because of that. See other elevation. If it is not there, the Chintak method, they may get aspirated. And utensil modification, the utensil modification and food texture is plays a major role while food intake initiation. Sir, next, sir. Sir, full screen is not coming, sir.
Still, I think you need to wait for some more time. Is it visible now, full screen? Hello, Ganga, can you hear me? Your audio is again, still it has gone muted.
Sir, now I can, sir.
Yeah, now please go on.
Make eye contact with the persons to whom you are speaking, and socialize in small groups or one-to-one interaction, and ensure that the people you are communicating with wear their eyeglasses and hearing aids as necessary. Use video call instead of phone calls to communicate appropriate way. Record feedbacks and show them, and they may feel very comfortable. And use gestures while talking with the patient. Why? Because in the persons with Parkinson, they may not focus only one sensory skills, so that we need to integrate all the sensory skills, such as like visual feedback as well as auditory feedback or touch, tactile sensation. So we need to use the different kinds of sensory systems necessary.
Yeah.
Tips to maintain speech in Parkinson's. Take a deep breath before you are starting to speak, and take a pauses between phrase to take in another breath. Express your ideas in short, concise sentences, and speak louder than you think is necessary. Vocal hygiene and practice breathing exercises. So now necessary. See, prevention of aspiration in persons with Parkinson's disease. So this is very, very important topic. Why? Because of the due to aspiration, this is causing pulmonary complications such as aspiration pneumonia, like that, fever, dehydration, like that. So if the patient follow the SLP prescribed food texture and taste, that may minimize the patient aspiration. Why? Because of due to the movement slowness, the oral articulators may not move in an appropriate way, in appropriate time, and in time being, so that the patient may get aspirated. To prevent that, follow the prescribed food texture and avoid distractions while eating. See, if you are in a crowd, or if you are in a hall, there is so many distractions. If seeing the TV or listening something like that, if the patient may not focus on eating, so the adequate alertness may not come. Due to that, the patient may not initiate their tongue movement, or as well as the iolaryngeal elevation. So to avoid that, uh, follow the recommended things. Avoid distractions while eating. So bed management. Next, bed management. See, to maintain the adequate postural management, bed management is the most important factor. If so, preferably 35 degrees to 50 degrees is the most suggestible. So head elevation, so reduced food ingestion. Next, reduced food ingestion and increase the swallow rate while eating or drinking. So why? Because of speed acceleration takes place a major role. How? See, swallowing is a highly respiratory and digestive tract and oral mechanism, as well as laryngeal mechanism, dynamic function. So if it is not coordination in breathing and laryngeal system, as well as digestive system and articulator system, the patient may get aspirated. So please reduce the ingestion rate and ask the patient to swallow fast manner, so that can help to follow the within the time being factor. So next, intermediate voluntary swallow or pseudo swallow, so that can helps to clear the if it is there any oral secretions, and following home management plans without fail, and patient attenders are patient therapeutic simulation programs most helpful. Why? Because of um, persons with Parkinson's disease, this management is cost effective. Due to that, we used to simulate the patient attenders or patient, and will train the therapeutic activities. Next, sir. Discussion.
Okay.
Sir, anything? Any questions, sir?
Thank you so much, Gangaraju, for highlighting the issues in Parkinson's disease of speech problems and also the swallowing problems. And also you have given very rich information about what kind of therapeutic techniques you are following in your practice. And also you have highlighted what are the different approaches we have to treat this kind of Parkinson's disease symptoms. Thank you so much for highlighting all those. In spite of having so many glitches, we could able to successfully complete this session. And now the session is open for the discussion. Anybody have any question? Please, you can ask us. All the whole the panelists are here. I think you can ask any question on any of the allied health professional. Like last previously, so many people have finished their previously maybe 3 to 4 people have finished their presentations. If you have any question on these 4 people, you can please put your question here. They're ready to answer your all queries.
Why I put together the speech exercises and the swallowing exercises together means, see, the speech and swallowing exercises are same. There is no differentiations. The only thing, SLP need confidence on that. How it is, the applied therapeutics is the most important. How we are managing the patient, how we are treating the patient with the passion. That is most important. So lacking that confidence, among the SLPs, they may feel, yeah, swallowing is a little difficult to manage, so that they may feel like that. But I thought it is all the speech and swallowing exercises are same. That's what I mentioned, the same speech techniques and voice techniques, and the language technique, as well as the respiratory techniques. This in general, we used to treat the patient like this.
Right. Thank you for clarifying that. I think many speech pathologists and audiologists are listening to your words. I think they'll definitely apply this in their clinics. So now I request all our participants, anybody have any question, please you can ask so that we can move on to some other session. Let me see the chat box. Some questions are there. No, it's only about audio is not coming. Okay. Somebody has asked some question. My question to Dr. Gangaraju, how do you deal with a person with cricopharyngeal spasm?
So in generally, cricopharyngeal syndrome, they go for myotomies like that. So, but in general, the patient may not feel good to go for surgeries, so that they'll go for in general speech and swallowing therapy. So in speech and swallowing therapy, we'll focus on mainly on phonatory exercises as well as resonatory exercises and the vocal exercises. We used to focus on that.
I think the person who has asked the question, I think he has got the answer. Still, if you are not satisfied with the answer, please you can talk to the.
Please raise your question, please.
Yeah. I think one more question we have. Let's see. Somebody. Don't we focus on his swallowing? Somebody's asked question again, reverted.
Sorry.
Don't we focus on his swallowing? As she replied, she or he, I don't know, because I could not able to see the name.
See, in generally, I thought there is no difference in between swallowing exercises as well as speech exercises. Both are same. But why? Because of speech mechanism and swallowing mechanisms are same, except that upper digestive tract. Otherwise, the all the mechanisms, speech and swallowing mechanisms are same. That's what. First of all, see, as a speech therapist, for misarticulation, we used to use that place of articulation and manner of articulation and tongue strengthening, as well as breathing exercises. Now, in that, see, in oral preparatory stage or oral dysphagia, as a speech swallowing therapist, I can focus on oral strengthening and range of motion and the coordination. I used to train the patient. So after the same thing, see, place of articulation and manner of articulations are just applied here. That's what I can achieve, or I can overcome that oral preparatory swallowing. After that, after that, if it is there any pharyngeal dysphagia, so I can most probably in pharyngeal dysphagia, there might be cricopharyngeal spasm or epiglottic fold inability to move, or vocal cord palsy. That may these events may cause aspiration. So and based on the diagnosis, I will focus on the particular targeted area, such as epiglottic elevated procedures, and vocal cord movement elevated movement induced therapeutic exercises, and as well as breathing exercises that can help to overcome the pharyngeal dysphasias. So I think not all speech and swallowing exercises are same. That's what I mentioned. I think not all speech and swallowing exercises. Sorry, Mali. I think not all speech and swallowing exercises are same. It's completely depend on the type and the severity of dysphagia. That's what I'm saying, doctor. See, if it is in oral dysphasias and the pharyngeal dysphagia, it's depends on their swallowing difficulty. We used to treat the different. We used to choose the different kind of treatment approaches. See, you are that's what, based on the diagnosis, we'll go through that. And speech therapy exercises will strengthen the muscles, but didn't improve the speech pattern and production. So, what type of dysarthria is seen in PD? Hypokinetic dysarthria we can see, Andy. What type of dysarthria is seen in persons with Parkinson's disease means hypokinetic dysarthria. We used to see that. So next question: speech therapy exercises will strengthen the muscles, but didn't improve the speech.
Sorry to interrupt you. And also, Gurvinder Jeet Kaur, she has asked one more question. The question is on how to do assessment to calculate speech disability.
Speech disability, no, sir?
Yeah.
Sir, based on the you are asking about the disability. So, sorry, sir. Frankly, no, I didn't classify up to now. Why? Because of speech disability means in generally I used to evaluate the all the speech system and the language systems as well as language components and the upper aerodigestive tract also I used to see that. But up to now I'm unable to classify the disability. Why? Because of this is entirely legal part. So up to now, I'm sorry that.
Okay. Can Gurvinder Jeet Kaur, can you answer on this? If you have anything, on this, if you can add something, please you can add it up here.
Sir, G means Gurvinder Singh.
Yeah.
Sir, speech therapy exercises will strengthen the muscles but didn't improve the speech pattern and production. But the swallowing exercises will improve the functional mechanism. You are answering, sir, or questioning, sir?
No. Actually, she's trying to justify what she's trying. Means like whatever you answered, right? So that's right on that.
Okay. So, see, in my practice, in speech difficulty, I used to observe that bite pressure also plays a major role, and swallowing as well as speech rate. See, in anarthria cases, all speech mechanisms may normal sometimes, but patient still unable to speak. There will be an dysarthria, and anarthic patient, even though it is motor speech disorder, the patient may not swallow. So in that condition, we used to see that electrical stimulations also. So that can improve that bite pressure, and which can help to improve the speech rate.
Okay. We have one more question. Kindly help us in understanding what's your call on Ryle's tube removal in a patient with Parkinson's disease.
In the sense?
She is asked about Ryle's tube removal.
So the protocol. So that is very important. Why? Because of, see, if patient aspiration free, we can remove the feeding tube or Ryle's tube. So based on the swallowing examination, so pre-Ryle's tube removal swallowing examination we used to conduct here. So for every patient, if they want to remove Ryle's tube, we used to go and examine the swallowing mechanism as well as speech mechanism. So if we feel there is no aspiration, or if it is condition good comparatively previous condition, so we can remove that. If basically the Ryle's tube utility is the only to drain the digestive contents as well as the to prevent the aspiration and bypass the oral route. So if the patient is able to taking, or there is no aspiration, there is no secretion content, then we go for remove the feeding tube.
Okay, I think Gangaraju has answered this to your question properly, I think. So, and we have one more question from Vinita. She's asking, can we be provided based on the level of phases of swallowing the specific therapeutic techniques? Is there any specific based on
I can provide you different kinds of therapeutic techniques. So it's a vast subject. So can you post your mail ID? I can share those techniques.
Yeah, please, Vinita, please be, just drop your
Why?
questions to
Because
the
of the oral preparatory stage will have different kinds of techniques, and pharyngeal dysphagia have different kinds of techniques. And also, most of the speech language pathologists may not deal the esophageal dysphasias. So, but SLPs can manage the esophageal dysphagia also. Why? To enhance their movement, esophageal movement. So, in dermatomyositis cases, there will be slow movement, slow esophageal movement, and food reflection will be there. So we can improve their esophageal motility unless it is anatomical disturbances or anatomical changes. So if it is only physiological changes, we can treat this. So it's based on the different kinds of the difficulties. We used to different kinds of strategies. I
Okay.
can mail you. Please post your email ID.
Yeah, and also we have one more question from Rani. How do
Sir.
you manage the patient with severe Parkinson's disease with dementia?
See, in dementia patient, neurocognitive therapies can help to overcome that difficulties.
Can we have Dr. Praveen sir online, so that he can, I think he can answer to this question. Do we have sir online, or else the same question will be mailing to him and he will answer to the same question. Okay, we'll drop a mail. Please, please share your mail ID. We'll definitely reply you on this.
Sir, inka question ఏదో ఉంది, sir.
Yeah, we have one more. 1 second. Yeah, there is a question from again the SLP is if there is a thyropharyngeus weakness which causes delayed penetration and leads to aspiration in persons with Parkinson's, what's your therapy approach which may help us?
Yeah, good suggestion.
Okay.
Next question, sir.
One more, I think. How do you improve esophageal mobility in dermatomyositis?
Myositis. Yes, good question. See, in general, so do you know, see, where the peristaltic movement will start? So in general, see that intraoral breath pressures and as well as tongue pressures and tongue oral propulsion that can elicit that movement. So to increase that motility, you need to build up that oral pressure strengthenings, as well as you need to improvise your oral propulsion strength. So if you are increase your oral strength as well as intraoral breath pressures, if you are intermittent multiple swallows for one bolus, that can help to overcome that movement issues. I think
yeah, I think we had so many questions on this on your presentation, as because people are very much interested, and this is also like one kind of uh, hot topic for everyone, because nowadays swallowing and this thing is on demand. We can see limited neglitologist. Now I can see Nikhila is also on neglitologist. She is actively working on this. So happy to see you all. Thank you, Gangaraju, for giving your insights.
any
And
questions, sir? Inka ఏమన్నా?
I think there is one more question somebody has asked again. Once again, how do you improve this? Answer to the same question. She has written something. Uh, she is saying that as per Nikhila, what she's saying is type and severity of Parkinson's decides the ability of swallowing reflexes, and in dementia, the severity of swallowing will be considered. And for example, if it is stage 4, then would recommend for PEG, and stage 3 could be on commercial feed. So what do you say, Gangaraju, on this? She's saying that, because she's also a gynecologist, she's working on the same field.
Sir,
So,
can you repeat the same question, sir? Can you repeat the question?
question, not question, she's justifying her this thing. She's saying that type and severity of Parkinson's disease decides the ability of swallowing reflexes, and in dementia, the severity of swallowing will be considered. And for example, if it is stage 4, then we would recommend for PEG, and stage 3 could be a commercial feed. Did you understand anything on this?
Yes, sir. But she said good, but the thing I am not agree with that. Why? Because it's completely based on the clinical status.
Okay.
And clinical status, and if the surgeon, if the physician may feel still they want to go risk free methods, they can choose any method. Not like that. See, today I seen one cases in neurosurgery case. So the patient has silent aspiration and symptomatically cough reflex and cough expectoration skills and breathing abilities. All those things they are fine, but still there is a problem in breathing patterns. Sorry, breathing rate. So she's get worsening. There are her oxygen levels. So even though now our surgeon suggested effective as well as that tracheostomy also. There is no clear cut indication, even though, but it is completely patient condition and as well as physician understanding and physician decision. It depends.
Okay, and also Nikhila is saying that stages are decided based on the symptoms only. Do you agree with this?
Stages are decided based on the symptoms. Based on the symptoms and not only symptoms, sir. So which are the diagnostic tools you are using? That is the matter. So symptomatically, they may show different kinds of things, and but where we can see the visual diagnostic, that may be different. So see, whenever I am trying to feed first time in patient, they make first for 2 bites or first few sips of water, patient used to cough. Why? That is due to that only temporalysis and as well as the that oral dryness. But whereas come to the physician will say Gangaraju, he is coughing. What can I do first? Sir, let me do the detailed evaluation. Then I will know about the condition. So I can introduce the all semi-solid and solids. After detailed examination, I can show that differentiation. So for every patient, there will be some cough while we are initiating the food. So due to that, we can see if it is okay, he is aspirating, do not feed. That's not meaningful, I think. So complete evaluation is the most important factor.
Okay, and we have one more question from some SLP. Can you name few diagnostic tools for determining severity of Parkinson's and dementia? I think you talk about Parkinson's. Okay.
So in Parkinson's, so you are asking about the swallowing or
No. Diagnostic tools for determining severity of the Parkinson's disease.
So you are asking about that, huh?
Yeah.
Okay. In general, I used to exam up to now. Sorry, I'm not use any kind of tools like that. But I used to only motor speech evaluations. In general, motor speech evaluation.
Okay.
Why? Because I used to go most practically.
Okay. So
Sir, I agree. Clinical. What is this? I agree that clinical examination. Sir, a question. What is that question, sir? I agree that clinical examination needed, but based on
stages, I think it would be decided.
Yeah, it's a mixed, sir. Mixed component will be there. Symptoms as well as diagnostic criteria. Can you unmute, sir? What?
No, she's asking to unmute her. Just 1 second. She can 1 second. I'll unmute her once again. Yeah, now I made her. Yeah, ask to unmute. Nikhila, you can unmute yourself now.
Welcome, Nikla. See, in some cases, we used to use that even electrical stimulation also, sir. That is transpharyngeal electrical stimulation, such as like that phase. And as usual, that and supralaryngeal electrical stimulation also we used to get that.
Okay.
So it's a completely depends on the diagnosis, the therapeutic interventions as well as. See, most of the speech pathologists lacking their confidence. That's it. Otherwise, all things are same. Nicola, meanwhile, you can try to.
Okay, not an issue. I think you can unmute yourself from your end because the settings are like that. You can, the flexibility has been given from here.
Actually, stages are decided based on the can you name few diagnostic tools determining severity of Parkinson's dementia?
Yeah, I think we have mostly cleared all the questions, I think.
Sir, we attempted all the questions, sir.
Yeah, we have mostly covered all the questions. Anybody still have any question on this? Please, you can ask us as we are about to close this.
Sir, first question, Abba edo adigaru
My question has not been answered, sir. I've asked about the question that is, if there is thyropharyngeal weakness in patients with Parkinson's and there is delayed penetration which leads to aspiration, what would be a therapy approach for us? Should we keep them on Riles tube itself, or what can be done with those patients, sir?
Yeah, you should focus on the hyolaryngeal elevation in exercises. That can help you.
Hyolaryngeal elevation is there. The only thing is there is no pharyngeal contraction. So how do we improve? For patients with Parkinson's, we know that they won't be able to develop that kind of pressure again to develop that kind of contraction. So what would be your measures, sir? Effortful swallow we have been using, but what would you?
See, effortful swallowing is always a compensatory strategies, which won't helpful. The only thing is
Effortful swallow is rehabilitatory because we'll be activating the muscles, right? Compensatory would be head tilt and the chin down maneuvers.
Dr. Sir, let me complete. See, Sekus manual and this what is the compensatory strategies which won't help to overcome the swallowing difficulty, but it will bypass the current situation. So, in that condition, you can train the patient on hyolaryngeal elevation exercises as well as the epiglottic exercises as well as laryngeal exercises as well as phonatory exercises. Hello.
சொல்லுங்க சார்.
Yeah, please.
Hello.
Ganga, you go on.
So those exercises can help you. So, and it's a treatment improvement. Improvement will be there, but the time factor is the most important factor. Doctor? Hello?
Yeah.
Sir.
Okay, Ganga, please.
That, sir?
I think he has clarified your doubt. If you have any question, please ask.
Sir,
yeah.
Sir,
higher laryngeal elevation is there, sir, for this patient that you were speaking. But the only thing was he's still aspirating delayed channeling. So higher laryngeal elevation, how do we don't see any we didn't see any this thing, sir.
Thyrolaryngeal elevation.
Thyrolaryngeal card, sir. Thyrolaryngeal elevation is there, sir. Excursion is there. Thyropharyngeus weakness is there, sir. That is what we have noted. And what would be a therapy approach? Because we were trying effortful swallow. The patient was not able to develop that kind of effort. So how do we do it అని మా doubt was.
సార్ మీరు అంటున్నారు థైరోఫారింగస్
Sir, weakness is there in the patient. Hyolaryngeal elevation is normal.
మీ వాయిస్ కట్ అయింది సార్.
Did you get it?
రైట్ నో ఓకే.
Okay, sir. Okay, sir.
Hello. You can ask, yeah. So questions are knowledgeful, Andy. So if you are not ask the same questions, you may miss learning those things, and even also I missed that learning things.
Yeah, exactly. You know, like there are be so many questions have been asked. Okay, few maybe not able to satisfy you, but still you can ask questions. Maybe you know, learning is a process.
So your questions may give me a chance to learn those things. So please ask questions. Hello.
Nagini, you're saying something. No, your voice is not audible. It's very poor, very low.
Hello, sir. Now I am audible, sir?
No, Ganga, your voice is audible, but Nagini's voice is not that audible.
Gautam Nikla. Hello.
Or else, Nagini, what you can do is you just drop your question in the chat box, because we could not able to hear your voice clearly.
Nagini, are you there? Drop your mail ID or your phone number. I can talk to you, or I can mail you the answer. Hello. I think, sir, no questions.
Okay. Let's move on to our closing session. I think
yes,
almost we have finished 5 sessions this day. Since from 2 o'clock to I think now it is almost close to 5. Still, anybody has any question? Please, we are closing this now. Okay. Dr. Gangaraju, now I would like to give you this to close this with your vote of thanks to all our panelists and also to all our participants.
Yeah, sir. First of all, I would like to say thank you to my management, KIMS management, and I thank to organizers KIMS and the Telangana Audiology and Speech Language Pathologists Association, President Sarji and Secretary Sarji, and the host Dr. Arif Sarji and Dr. Rajendra Sarji. And I would like to say thank you our HOD Dr. Sita Jayalakshmi Madam to give permission and give constant support for this webinar and as well as her guidance. So thank you so much, Madam. Without you, I couldn't conduct this kind of a webinar. Thank you so much, Madam. And Dr. Sudhindra sir also given a lot of support for me to conduct this webinar, and he's guided so many things. Thank you, sir. Thank you so much, sir. And Dr. Praveen Yada, sir. So when I asked the sir, and he conveyed his willingness immediately without any questions, and he's encouraged a lot of things, and he used to guide me, and he used to say how the webinars will be here, and those things he used to guide. Thank you so much, sir, for guiding me and as well as enlightened session. And I would like to say thank you for all participants being with patience, and I would ask apologizes if it is any technical issues or if it is I'm unable to answer your questions. please forgive us and let me give a chance to learn from you and give me some chance to share my knowledge with you. So I would like to ask apologizes. So thank you everyone. I especially Arif sir and the Imas sir and as well as Nagendra sir and Rajendra Kumar sir, and most probably they are conducted uh, very good webinar. Thank you so much, sir. And once again, thanks to Dr. Sita Jalakshmi Madam, Dr. Praveen Yada sir, and Dr. Sudhindra sir. Thank you, one and all.
Yeah, now I request all the participants to turn on your camera so that we can take a group picture. So I request all of you to please turn on your camera.
So NMS Reddy sir kuda nenu na thanks cheptanu sir, at the Pramod sir and all the participants whoever the, and special thanks to Nikila and Nagini. So your Nagini also is given a good question, but I may reached or I may not reached, but please mail your question, then I can try to answer your question. So that can help you to learn from your question.
Yeah. Hello, I think Shahid sir also joined. We can see him. Hello, sir. Welcome.
Science sir.
Yeah, Jyotilal Das. See, all those very senior people have joined and very actively listening.
Sai sir, thank you, sir. Thank you so much for joining. And when I was student, you are there in Kadapa. Thank you so much, sir.
Yeah. I request in again all other participants to turn on your camera so that we can take a group picture. It will be like a memorable moment for us. Maybe this. Let's make it a little more memorable.
As I request all participants, please open your videos.
We can see Naresh also online. Yeah.
Pragna Purushetty,
Jyotilal Das and RKP sir, and I request Suresh the camera and Dr. NMS also.
And Suresh, Vinita madam, Vishnu.
Ji, thank you so much for asking questions and giving some kind of inputs. And thank you, Vinita Garu. And thank
Sir,
you.
na photo sir.
Yeah, I can see plenty of people joining through video call, means turning on the video. So let's take a picture of all the group members. Once again, thank you all the participants for taking out your valuable time and making this webinar very valuable. And these kind of webinars will be doing in future, because this is something special where multi-rehabilitation, multidisciplinary approach, multiple means like you can see this number of professionals from different fields, like medical field. Also, we had a neurologist, and also we had a physiotherapist and dietitian talking about Parkinson's disease. I think altogether, I think let's work towards the betterment of Parkinson's disease management and also assessment. Thank you so much once again for joining.
I would like to say thanks to Radhika madam also. Sorry, I forgot your name, madam, and that. And ఏమైనా తప్పులు జరిగింటే క్షమించండి, ఎందుకనంటే since it is my first webinar from KIMS.
No, it was wonderful presentation, Ganga. You are having a great experience. You are having a very
really.
We really appreciate your efforts for getting all this staff of KIMS Hospital. Yeah, I think NMS has.
Hi. Good evening, all. Yeah. Gangaraju, Dr. Gangaraju is really day by day improving very well. I am really proud of you. You started first up with my clinic, and yeah. Really, you are doing amazing job, Ganga. Yeah, I bless you. With same passion, same thing, you grow up. Definitely, our Tasalpa and we all there with you support. I'm really proud of you and congratulations. Thank you so much for conducting this kind of webinar with the team, involving all the team. So,
thank you, sir.
NMS for appreciating our EC member, Dr. Gangaraju. And now I request our Shahid sir, if you have anything to.
Yes, sir. Shahid sir.
Please, if you want to
Sir,
add,
I'm very enthusiastic, sir, on your
want to listen
about
something
your
from
voice.
you.
Sai, sir.
Your voice is not audible, sir. Still, it's. I think you have to join your ad. Audio is not visible, audible, sir. Still not audible. I think you have to join audio with your phone. There will be some notification, and that you have to. Okay, or else you can message through chat box, sir. Thank you so much. Naresh, how was the presentation? How was the sessions? Like, there were 4-5 sessions. You want to say something on this? Okay, चलो ठीक है. Dr. Rajendra Porika, sir, please, if you want to add something about how was the sessions and everything.
Thank you very much.
Yeah. Okay. So then let's close this session. I think wonderful day. We had so many professionals talking about Parkinson's disease. I think by this we are carrying most of the information. I think we have gained so much information about all this management of about Parkinson's disease. Thank you so much once again. We TESELPA definitely are in the front to organize these kind of events, webinars. Now, this is the online webinar, but in future, we'll definitely plan something offline. So we want all our member support. Thank you for joining. In spite of so many glitches, you people are always there. Even the participants, number of participants did not drop to 0. It was stable throughout this session. Thank you so much once again. So let's close this. Okay, chalo. Thank you. Bye.
Thank you.